Great. We're thrilled to be here and part of MedX and to share with all of you our story of how we included everyone in a process that's maybe more low-tech than some of what we've heard about today, but certainly, in our opinion, quite innovative and a path to providing high-quality care and engaging multiple stakeholders from around our campus. My name is Patrick Kneeland. I'm an internal medicine hospitalist at University of Colorado Health and also our medical director for patient and provider experience. And in that role, spend a lot of time thinking about how do we actually engage the multiple levels of stakeholders in an academic medical center to both educate and deliver top-notch, high-quality care, and how do we continue to innovate in that space? And that's the story we're going to share with you today. So let me give you some context. I'm just going to move this slightly over here. Let me give you some context to set up the stage, and then our phenomenal design team is going to tell you sort of their version of the story. This intervention took place on an 18-bed medical surgical unit. And it was a unit that was a little bit in dire straits. Lindsay McGinnis on the left there is the nurse manager of that unit. She came to me and said, we're struggling. We're a med-surg unit, not necessarily the most sexy of places in a hospital, as a lot of you know. We have multiple admitting services to this unit. So on any given day, there's internal medicine patients there, there's surgical patients there, there's patients from odds and ends, other specialties, and that makes for a lack of sort of cohesive community and on the unit. It makes it really culturally complex. Our patients are telling us their experience on our unit is not that good. People are leaving the unit. And even if we're doing the right thing medically for them, they're not necessarily satisfied with their care, and we want to get better at that. Not to mention our staff are turning over. So Lindsay shared with me that 70% or more of the staff had turned over in the preceding year. And if you're trying to build a culture that takes care of patients, that kind of turnover is devastating. And not only that, but because we're a med-surg unit, we have inexperienced staff. So we have new staff coming on because of turnover, but also our unit is a place that a lot of nurses see as a stepping stone to other cooler parts of the hospital. So those are our challenges, and we got to do something new and innovative to solve those problems. And we spend a lot of time in our setting, and people can probably relate to this with top-down approaches to trying to implement and plug in best practices. And when we were looking at this unit, we said, that's only going to get us so far. We got to rethink this. And so what we're able to do is actually think about how we're going to engage everyone in co-designing what we want this unit to be, what we want the experience to be like for patients, but also what we want it to be like for the folks doing the work, and how do we design and restore joy to the folks that were doing the work. So we used a design thinking process, one that I learned right across campus here at the D School. And Lindsay, another physician leader, our process improvement team, and I got together and said, all right, let's try this. We haven't done this in any other part of our hospital, but we're going to build this thing. We're going to figure it out. And we started with empathy-focused intelligence gathering, and all that means is we actually went and watched and listened and interviewed and talked to patients and nurses and frontline techs and the physicians on the unit and gained empathy into that experience. We did over 20 hours of observations, which mapped not just processes, but actually the experience journey for both the patients and the workforce. And we did a series of interviews, which we'll get into in a little bit more. We then used that to build 4 core areas of insight that we designed around. So we invited about 50 people to our design session that included physicians, nursing, attending physicians, resident physicians, Thea, a medical student, and giving that perspective, pharmacists from the unit, case managers from the unit, literally anyone that we could think of. And we used the patient insights to infuse that day with the empathy piece and the design around that. So during that day, we actually opened the space up to some creativity, and people told us afterwards, I've been working here for 5 years, 10 years. I've never been in a place where I felt like I could utilize that creativity, where that space was truly open for us to think in a new way. And we at the end of the day came out of there with 4 prototypes that we brought back to the unit. And we'll talk about those and describe those more. We love the prototypes that came out of that, and they've been successful in terms of the unit, but we're also incredibly proud of the actual process we used. So what happened, and those are the prototypes here in the pictures, and we'll explain those as we go through. So wanted to start our panel actually with Thea, who's a medical student, and I'll let Thea introduce herself. And then I'll start with a question around your education, and because a lot of the focus here is around education. When we say we want to include everyone, we certainly want to include our med students and our trainees. So wanted to hear from you kind of how you got involved as a medical student and how this experience has augmented your medical school experience.
Sure. So I received my undergraduate degree here in product design. I came into medical school knowing that this sort of work, this, improving the patient experience was something that I wanted to be a part of, and I wanted to do that as a provider in the future. I was lucky enough to, meet Patrick, Lindsay, and Tasha, who brought me right in and helped me feel right at home, even though, this was one of the first few times that I'd been in this sort of clinical setting, and they gave me the power and sort of the permission to be involved in this type of work.
Cool. And you've shared some of this with me, but I'm also interested to hear more about how you kind of see your involvement fitting in to medical education in general. Is this something that most med students should have access to? And how should we be thinking about that as we're building curriculum and engaging medical students in this work?
Yeah, so a lot of medical education right now is done in the classroom. And we spend a lot of time in lecture halls being told how to engage with the entire healthcare team. How do we engage with nurses? How do we engage with our attendings? And it's a lot different, I've realized, going into the field and working with all of you and actually having that firsthand experience. I think it's something that's really valuable if you are interested in this type of work.
Nice. And I'm hoping you can share a little bit about the work you did with a couple of the other med student colleagues on the unit around whiteboard use and the sort of the iterative prototyping you did around design work with the whiteboard, which is the picture you can see on the far right there.
Sure. So what Dr. Kneeland is talking about is the project that we were working on this summer. I was really interested in communication on our unit. So we know that there's a problem with communication on our unit, and one of the tools that we use is the whiteboard, and that is a means of communication. But we were realizing that it wasn't being optimally used. We found that physicians were telling us that they often checked the whiteboard. There's a specific section of our whiteboard that reads family messages, and they told us that they checked this part of the whiteboard for questions that they thought were being written by patients and their families for them to answer. But when we went around and actually did our user-centered research and actually asked patients, we found that only 10% of patient rooms had anything written in that section of the whiteboard. And we wondered why. Why weren't patients using the whiteboard like physicians were thinking that they should? And after talking a little bit more to patients, what we found was that they were actually fearful of writing on the whiteboard. They thought that being in a new setting, being in a new hospital for the first time, they thought everything was doctor-owned or nurse-owned, and that if they touched anything in the room, that they would get in trouble. So we wanted to make the whiteboard a little bit more patient-centered, and we changed that specific section of the whiteboard to read, instead of family messages, to read, patients, please write questions for your healthcare team below. And through that really simple intervention, we found that patient engagement, as measured by utilization of the whiteboard, increased from that initial 10% to 30%. So we did something really simple, simply changed this section of the whiteboard and reframed it in a way that was more patient-centered, and we found that we had drastic drastic changes.
Yeah. Thanks, Dan. And the part I would add to that is because of the work that she and a couple of her medicine colleagues did around the whiteboard, some of that design is actually being implemented on kind of the new version of our system-wide rollout of our new patient-centered whiteboards. Just wanted to ask a final question around, for you, what are, having not spent time in a clinical setting, being given this permission to kind of explore the clinical setting, get to know nurses, get to talk to patients from a very user-centered focus. What were the most surprising or interesting things you found that maybe you didn't anticipate, coming into medicine?
Yeah. So what surprised me doing this project, I guess I was surprised by how much support I got outside of the classroom. There's a lot of requirements of medical students. There's a lot of checkpoints that we have to meet in order to go on to the next phase of our education. And a lot of times we're fearful and we just want to make sure that we can fulfill our duties. But when I started this project with you, Patrick, you just sort of pulled me right in and sort of let me do, what I knew I could do. And I thought that was really, I guess it was, I don't know if it was surprising, but it was certainly different than what I'd experienced in my classrooms.
Great, thanks. So let's move on to Tasha. Thank you, Thea. That's great. Tasha, want to hear from your perspective, as a nurse who's worked in this unit for a few years. Kind of sharing from your perspective, what was innovative about this process? What maybe was similar to other things you've tried to do strategically, or different about the process that we walked through?
So as a floor nurse on this floor, and then as a floor nurse for 10 years in different hospitals, I've been to this meeting where people all come together and try and come up with great solutions so many times. And every time is the same thing, right? Like people come in, they get really excited. It's kind of like a back scratching activity. Everyone feels really good, and you go home and nothing happens, because the suggestions that were made were things like massage chairs would really make nursing better. And that just is, one of those things that is looking at not the core of the problem. And I think what this was doing and why it was innovative was that it was looking at what brings you joy at work, and why did you get into this in the first place, and how can we work together to make something really special here, because we take a lot of pride in where we work. And so we were talking about permission and what it felt like as a participant, because the three of them were really leading the meeting and I was just kind of there. It felt like we were given permission to be proactive, which in nursing is very different. Nursing is 100% reactive. You do what the physician instructs you to do. You do what the patient asks you to do, and you don't have a lot of that proactive mindset, which is what I think drives asking the right questions and drives paying attention to the right things on the floor. When we talk about lasting change and how to make these kind of ideas that we have, in an area like this actually progress to real action, we have to look at how humans behave, and what we know about human behavior is you have to link it to something that you already do if you want to have lasting change, and you have to practice it constantly. And so what we were able to do, we started with this proactive mindset, and then we took these 4 ideas and we linked them to things that we already do on our unit all the time, like flossing your teeth after you brush your teeth. And then we were able to become excellent at them just by practicing so much.
Great. And I think this concept around joy, restoring joy and purpose to the work comes up a lot in the wellness and resilience conversations that are going on in healthcare right now. And so I'm glad you brought that up. And it's actually an incredible challenge to figure out, how do you build resilience, not by doing something extra after work, not by meditating before work, but restoring joy in the work. And so I'm glad you brought that up. I want to make sure we touch on the actual design element that came out of of this, the admission timeout that you've really taken on and owned and been proactive around on the unit. I want to make sure folks have a chance to hear about that admission timeout piece and how that fits into that restoring joy in the workplace.
So the admission timeout was our way of solving two problems that we had on our unit. The first one was that we felt that when patients would come to the floor, it was unwelcoming, it was disjointed, it wasn't very organized. And then the other problem we had was something that comes up for a lot of people, our lack of communication or just poor communication between providers. So what we did was took something that always happens, our admission. We always get admissions, and we always have to ask physicians questions and have a touch point with them. And we just made it structured. So we developed kind of a surge at the bedside whenever there's a admission. So we have nurse, charge nurse, CNA, sometimes the PSC, and hopefully the physician. If the physician can't come, we'll call them and have a conversation with them next to the patient. And the patient knows that that's their physician on the phone talking right there. And we bring them a hot lavender towel to kind of refresh themselves and welcome them to the best unit in the hospital. And we ask this series of very short questions. It takes 2 minutes or less. It's the same questions that we really want to communicate all the time with our providers. We get the heavy hitters out of the way. What's the diet going to be? They're nauseous. Can we get something for nausea right now? Will there be consults tonight? Are there going to be any procedures tonight? So that we can kind of start that plan of care where everyone's involved right from jump. And then at the end of that, the last question is we ask the patient, what's your primary concern right now that you want your doctor to be aware of? Which has been, people have reacted very positively to that. The patients really feel like we are communicating. They can see the communication in action, which has been very, very good.
Yeah. And so for folks who maybe aren't spending a lot of time in their clinical unit, this would seem like maybe it's kind of an obvious solution. What have been the obstacles to something like this in the past, and why is this new, and why does this feel different than your usual experience?
I think we just took ownership of it. From the beginning, we established this is something that we're going to be doing going forward. This is what's best for the patient. And I think everyone wants to be awesome at their job. That's what we all want. And this is a way for us to do it and to show that we're doing it. And we want to give our patients the best care we can. And nurses felt uncomfortable calling physicians. They felt like they were being bothersome. Or we'd run into that problem where you call the physician, you talk to them, and then, 2 minutes after you get off the phone, the patient calls and says, well, I have this new question. And so we just were missing that piece where we really brought the patient into our communication with the physician. So this has really given us that everyone is included in the admission. And I think it sets us up really well from the beginning for their whole hospitalization.
Yeah, thanks. And you were sharing with me a reaction to one of the patients who, so again, this happens at the bedside at the time of admission, and you as the nurse hung up the phone and the patient said, you and the doctor talk about that stuff? That's pretty neat. So, yeah, interesting from that standpoint as well. Want to give you a chance as well to talk about Smashup, and this is the planets sort of colliding here in our graphic. This thing that emerged called Smashup, which is one of those things that we could have probably never thought of if we weren't kind of in a design mindset and design space. But why don't you describe to us what the Smashup is and how this has helped redefine the culture on the unit?
So for Smashup, we brought together our physicians and our nurses forcefully. It's part of the reason why we call it the Smashup. So everyone's busy. Everyone has so many tasks to get through in a day, and the first thing that goes is that friendly communication piece. And so we first wanted our physicians and nurses to get to know each other, just so that you have that face-to-face contact, that you know people's names. So we developed a twice-monthly meeting for 30 minutes, 15 minutes for the physicians to kind of share their side and 15 minutes for the nurses to share their side. And we would have a topic like sepsis. And we'd ask the physicians, what does it feel like to you when you have a patient admitted? What are you thinking about? What are you worried about? What are your expectations for nurses that we may not know about when you have a septic patient? And then the nurses would share what they were concerned about, what our algorithms are. Sometimes we have a sepsis alert that we call if we see a particular set of vital signs and the physicians didn't realize that. They didn't know what our parameters were, so it was kind of eye-opening for us. So we have kept that going as different topics each time. And that's also been a very positive change because people feel more comfortable with each other, they feel friendlier towards each other, they feel more like they're on the same team.
Yeah. And this is a actually design element that came out of an insight, which is physicians don't know nurses on the unit, nurses don't know physicians on the unit. What are we gonna do about that? How are we gonna tackle that head on? And so we built this container, which is a time limited 30 minutes, as was mentioned. And there's really no agenda. So in the past, we've done versions of this where the physicians are there to teach the nurses about sepsis or about whatever medical topic, and there's clearly that hierarchy and that hierarchy gradient that's still kind of existing in that environment. This is about we're here to share our side of one part of our work experience, and we want to hear from you. How do you experience that work? So we did the sepsis one. One of the ones I was at that I liked, I loved being a part of was IV access. So something as simple as IV access. We were having a conversation with the nurses. How do you think about IV access? What are the most important pieces of that to you? And vice versa. Nurses were able to ask us questions. One of the things that came up is why don't you just always put in PICC lines, which are central lines, which make drawing labs and those kinds of things much easier on the nursing side, but have a series of side effects that make them untenable to be sort of the common thing. So nurses were able to ask those questions of physicians. And so what's emerged, and what I think has been pretty cool, and I'd love to hear your take on this, is not only is there a transfer of information, but there's a gained sort of empathy across discipline barrier that didn't usually used to exist, and there's this sort of encapsulating social component, which all of a sudden you're in the same room with these folks that you work with often on a day-to-day basis, but don't usually share that kind of space with. We talk all the time about breaking down silos, right? I mean, who hasn't heard that in the last week? We need to break down silos. The question is, how the heck do we do that? And this is our version of starting to break down the silos deliberately and around a specific type of design. So I can say from the physician standpoint, and hearing my colleagues talk about this has been a game changer in terms of the culture on the unit. So Lindsay, would love to hear your perspective as someone who's been a nurse leader and sort of challenged with leading what a little bit of a turnaround on this unit. Interested to hear your perspective on this approach and the elements of this, again, that have felt different to you from your leadership perch, and sort of the take-homes from your perspective.
Sure. So going back to sort of the design day that we had, it was back in August. I think what was really different from the start about this type of an event, a design event, like Tasha said, we've all been identified a problem, bring in the stakeholders, hash it out, use different methodologies for one day, get really excited, and then nothing happens. I think what was different from the get-go about this day was that we didn't go out to the staff and say, we have a problem, we need to fix it. We really presented it to them as, we're in a current state, lots of turnover, our patient outcomes aren't poor, but our satisfaction scores are pretty low. Some of our quality scores that are very nursing indicative are pretty low. We have to do something here, and we have a unique opportunity to be a part of this and make decisions and decide what we're going to do as the healthcare providers, nurses, physicians, case managers, CNAs on our unit. And we really opened it up to the possibility of anything, right? So there were no limits. Come, share your ideas. So I think that alone didn't make it feel punitive. So people didn't come into the room thinking, okay, we have a problem, we have to fix it. this may or may not work, but really the options were really limitless, and they came from the staff and providers that are providing the care at the front line. So I think that was different from what we typically do when a problem is identified. I think the other thing that's, from this one-day design day that really kick-started all of this, we've done a lot of work and we've had a lot of success. And so, as we all know, for healthcare providers and educators in the room, we have pressures from those above us to have certain outcomes, right? For many reasons, ultimately for patient experience and for patient safety and quality care. So obviously one of our drivers was outcomes. But I knew as a leader and in some of my previous experience that there was going to be no impact to keep driving into staff, that we need to improve quality, we need to improve patient satisfaction, and just keep talking about that when we didn't have a team and we didn't have joy in our work and we didn't have a common goal or vision. So I knew that we needed to start there. And I think probably I had recently just taken over this unit, so it was new to me, and I was familiar with a lot of the staff because they were across the hall from my other previous unit, but I just knew that nothing was going to happen until we kind of built that team. And I think, like I said, they thought I was crazy at that first staff meeting when I said, we're not looking at any outcomes or scores. Like, we're not even going to focus on it or talk about it for 6 months. What we're going to focus on is becoming the best unit in the hospital. We're going to be the unit where providers want their patients to be, and they're going to know and feel confident if they're on 6 East, those patients are cared for, they're going to get the best nursing care, and those nurses are going to ask questions. But we had to earn that, right? That doesn't just happen. They needed to work with us, learn our style, know what we expected of them, just as much as us knowing what they expected of us.
Yeah, I think it's a great point, and Natasha talked about the permission to be proactive, and that I can't overstate what a paradigm shift that felt like in the room for both nurses and I would say that physicians that were in the space. It's the difference between solving a problem and creating the future, and that's really what was palpable around this process. So curious. Why don't we start with the hard metrics? So, has there been an impact from this work on the metrics that people do care about, either because they're financially incented or otherwise?
Yes, definitely. So we've actually seen a shift in a lot of our outcomes. So turnover obviously is important to me as a nurse leader and to the organization, and really to the whole team, because it impacts everyone if you're training new people and new people are training new people and you can't provide the greatest care. As Patrick said, there was a lot of turnover on the unit in the previous year. Since sort of this type of work started and our fiscal year starts in July, we've had very minimal turnover. So I think it went from over 70% in the previous year to around 20% since July. So that's a huge indicator that staff are happy and excited to come to work. Some of the other metrics we've seen move are definitely our very nurse-driven quality metrics. So our catheter-associated urinary tract infections and our CLABSIs, our falls have significantly trended down. Our skin care, hospital-acquired skin care, wounds. And then as far as patient satisfaction, I can tell you we were probably about as low as you could get, like maybe in the single-digit percentile in willingness to recommend when this sort of all began. And although Patrick can speak to this a little bit better than I can, but although we may still be in, the lower 50% of like hospitals, we've improved significantly. I think by 20, 25 some percent. So that's a huge move in this amount of time. And I think it is directly related to the work that we're all doing together. We've talked a lot today about the disconnect between, sort of the patient perspective and provider perspective and aligning goals for the patient outcome. And I think that goes for connection with patients as much as it does between the different disciplines. We all have the same goal and we know it, and we walk through that door every day because we want to be there and provide the best care for everyone. But we have to break down sort of the barriers between each other and just come together and figure out, and design what's the best way to do this. So it's been really successful.
Great. And maybe do you have an anecdote or two, and Tasha, feel free to speak up on this as well, around the culture shift that maybe isn't felt in metrics, but that has shifted in your experience and how you've experienced the work and what your colleagues are saying on the unit.
I'll let Tasha answer that.
I think people feel so much more comfortable talking about being vulnerable and asking questions and saying, hey, I don't know how to do this, or this might be done differently here than it was in my last hospital. Can you help me out with this? And to both nurses and physicians, because it's kind of like we're all learning together, and if our goal is patient-centered care, then it's not like I'm going to be the best nurse and I want everyone to notice all my nursingness. I'm proving to the patient every time I go in that room that I'm doing everything that I can for them, and I don't have an ego about that. I'm going to tell people, I don't know how to do this. Can you help me? Because I want to give the best care to that person. So I think that nurses have been very honest with physicians, saying, this order doesn't make sense to me. And because of the Smashup, when they see each other in an informal environment and they can provide some insight to someone else, they feel valued. And then they feel like they can comfortably talk to them. And I think the physicians also comfortably feel like they can go talk to the nurse, and they can walk into the patient room and they can say to the patient, oh, Lindsay's your nurse today. You are so lucky. And I think that makes a huge difference in how the patient perceives the team and how the patient perceives their care.
Lindsay, what would you add?
I would just say that I think this is sort of my plug, but I think sometimes we get stuck in our own world. So we get stuck in the nursing world, and you get stuck in the student world or the physician world, and we forget how much our own confidence is boosted and how empowered we feel if we can interact with the other disciplines. So there's nothing more satisfying as a nurse, or Patrick can share with you a story as a physician, to sort of hear out loud a thank you from one another, or a great job, or wow, can you believe we took such great care of that patient, or discuss an outcome. But it's so important for us to just get outside of our comfort zones a little bit and appreciate other disciplines for what they have to offer that we don't. We've talked a lot about, I remind physicians all the time at any venue that I can, like, just a simple thank you or acknowledgement, anything goes so much further than you think it does. And it's easy, right? But it definitely transforms your experience.
Yeah, I think it's a great point, and I think it as it relates to the design work, I think the take home for me is that doesn't just happen organically, as much as we all would love it to. That really actually does require some sort of strategy. I think this sort of design process is one way you get at that. But if you aren't deliberate about it and you don't carve out a specific space for people to cross those boundaries and jump across what they're usually used to and comfortable with, it doesn't happen by magic. And so that's certainly a take home on my end.
Would you be able to talk a little bit about the design of the design day? Because I think, like, at least from a participant standpoint, it was so organized, and it felt like it was just very well, everything just kind of distilled to the end of what we were trying to get to.
Yeah, and I think it's important, because when we talk about, well, this sounds nice, but what are the resources sort of that went into it, and what would it take to do this? And we're having these conversations right now in our organization, is how do you take something like this and scale it so that all units, all clinical spaces have access to this? I think the biggest thing is that skilled facilitation piece. So coming in with a very clear path to carve out the permission, make good use. If you're going to take 8 hours of highly paid professionals' time and put them in the same room to do this, how do you do that thoughtfully? I think a big chunk of this was actually in that insight gathering phase. So we came to the table with 4 areas that we knew, because we had been spending time on the unit with patients and with the people doing the work. These are the key sort of trigger points. How can we design around these? My favorite question that we posed that day and we designed around was what would it look like if 100% of our physicians and staff were proud to work on this unit? And that's where some of that communication work emerged, and the Smashup came out of, along with some other really cool stuff. So all of that was deliberate and required upfront strategy, both in terms of getting those key points surfaced because we have voice of the patient, because we have voice of the staff and the physicians, but then facilitating around that. And there's a couple pieces to this. One is, and folks who are familiar with, the design thinking philosophy is how do you set up the creative space and give permission and the psychological safety for people to blow up whatever their paradigm is, and to truly brainstorm and to think outside of the box. And there's some activities you can do around that. And then the other piece that's freeing and I think completely different than most strategic planning sessions is we're not coming out of this with the strategic plan. We're coming out of this with a prototype of something we want to try. And the implication is it may or may not work when we get into the environment. And we have, this is not like the end of the process. This is the beginning with some really cool new ideas, and giving people the freedom on that day to say it doesn't have to be the perfect solution. This is something that human beings are going to interact with and continue to evolve. And so, all of these sort of interventions or solutions that came out of this have had multiple iterations since they showed back up on the unit. But that was a very deliberate part of the facilitation process as well. And the third thing is we brought in senior stakeholders at the end of that day to give visibility to the work and also to get resource behind it that we needed.
So the way that it looked from my perspective in that was it started off with Patrick coming onto the front and talking about we're going to brainstorm. If you think that helicopters landing on the top of the university hospital is going to solve our problems, then say that. And I was like, this man is going to kill me today. I cannot handle another thing like this. But it absolutely brought people, like you said, into a place of safety and a place where they could all just start talking about any kind of idea. And then we broke into these small groups, which were divided by service, essentially. So I was with a social worker and a pharmacist and an attending physician. And then we moved around the room looking at different areas of problems and, we're talking about wild solutions. And then we were given the chance to divide into 4 groups at the end into each one of the main prototypes we were going to work on. And my group was the admission timeout, which is why I ended up taking that project a little bit further. But we presented it to the group as this is our project. We've come up with something and this is actionable. And then they all gave us feedback on that. Is this going to work? And every service was able to provide that feedback to us. And then we went back and retooled it. And then, like Patrick said, presented it to our director of med-surg, and I think the CNO was there also. And it was a very high-level group for some of us to be engaging with. And it definitely made us feel that the hospital cares about this little unit. Like, we're here for a reason, and we should follow through on these things that we just said we're going to do. And part of our success, I think, has been that Patrick kept showing up. You'd see him walking around. You'd see him asking questions about how things were going. And then Lindsay, as our manager, would every single week hammer, what are we doing today for this? How far have we gone? Have we sent this out? Do people know about this? What's happening with this? And I think that's the real piece that came out of the sustainability, was that it just kept being hounded by leadership, and so staff didn't really have a choice but to get on board.
Yeah, and I would take a little bit of a different frame and say there was a different type of investment from folks who were, including leaders who were in the room, because they helped co-design. I speak for myself. There's a little bit more motivation when you're in there designing to see things succeed. So, I want to make sure folks can ask some questions. So this is getting us back to the overarching goal that Lindsay described. We were going to show you our metrics. I can show you that the HCAP scores have gone up as quickly as I've ever seen in a unit in our environment. Lindsay mentioned the turnover rates as well and the other quality metrics. But we've been pretty relentless in reconnecting to these things in the work, mindful of the metrics that people care about. but keeping our focus there. So a couple of key takeaways, I think, and hopefully these have come out before we let you ask some questions, but I think the interdisciplinary engagement of folks can be an effective way to sort of design innovative solutions within the restraints of what exists in a hospital right now, and what are the we're all looking for the next sort of technological advancement, and we're happy to take that on when that actually smooths workflows and that kind of thing. But what do we have right now, and how are we going to make the most of that and design with that? And we found that this is pretty successful for that, and really reconnects people to professional purpose in the process. The resource intensity, in terms of, we did actually 20 hours, like I said, of observation and interviewing before that full day event. And that's real resource, and it takes a certain level of skill, but there are creative ways to engage med students and other folks in helping with some of that work in ways that are also beneficial to students. But that front end sort of investment actually, I think, pays for itself down the road pretty readily. So we'll pause there, and if anyone has any questions, we're happy to answer. We have one here. Yeah.
Thank you. So I'm a chronic illness patient, but I'm actually also an experienced designer, but for a consumer, not in healthcare. So I found this really exciting to hear what you guys are doing and the approach that you guys are taking to this. I have two questions. The first one for Lindsay. In the beginning, you said that you decided that we're not going to attach this to outcomes, but were there any stakeholders involved that weren't sure about that, and how did you convince them otherwise? And then for all of you guys after that, what are you guys going to tackle next? What's next?
So yes, there were other stakeholders that were interested in the fact that maybe we weren't going to focus so heavily on outcomes. However, we could have gotten worse, but we were doing pretty poorly. So I'm not sure that anything that we were going to do, or by ignoring them, if you will, we weren't going to make them any worse. So my direct supervisor was aware of what was going on, and she put her trust in me, and was like, as long as you have a plan and you can backstep and change at any time, go ahead. I don't know that I announced it, from the rooftop to other stakeholders that we weren't going to look at it or discuss it, but I really felt and I knew that until we focused on finding ourselves as providers and as a team, it didn't really matter how much we talked about outcomes, because if we weren't happy walking in that door every day, the patients feel it. So that was the focus, and I think it's been successful. And now we're starting to talk about, the outcomes again, but there's more meaning for the staff and the providers when it comes to outcomes now.
The one thing I would add is it actually takes courage for leadership to open this permission as well. And we're fortunate that we had enough of that to actually open up this space. But it in large, stable organizations that have been relatively successful, this is a leap of faith to say, all right, go blow up the model and spend a whole day doing that. And it might not seem that way to folks who spend their time in creative and innovation-driving industries, but it absolutely is in a large hospital.
I think the second question, just really quick, was what are we going to do next? And we actually have talked about it a lot.
So many things.
Here today. So we've talked a lot about how we're going to now take this sort of design experience, and are we going to recreate another half day soon? It's been almost a year. And we're actually going to shift this joy that we've found in our work to the bedside. And it's coming from the staff members who are coming forward. Tasha's a main driver, as she's a super leader on the floor, but they are wondering, we need to be more professional. We need to take more pride in this place, right? So they're showing ownership over the patient experience without me even driving it, because they see it now and they're very proud of where they work. So they're shifting the focus to the patient, which is beautiful, right? Because then I don't have to stand in front of them at a staff meeting and tell them about all the metrics and the patient needs, because they know and they own it.
John Darby from Tufts University. There's been a lot of work published on cyber rounding, structured, interdisciplinary bedside rounding, and its effect on patient care and team performance. How did the product that you ultimately designed differ, or was it similar to the sort of published work out of Emory and other places around structured team rounding? Did you guys end up rounding as a team more formally, or was this more about a improvement in cultural communication on the floor that had nothing to do with interdisciplinary rounding on the patients?
Yeah, it's a great question, and I think those are some of the horizon pieces of how do we read, and that we're talking about today, how do we redesign even more fundamentally that interaction and that rounding process. I think part of what made this successful up front is that we actually designed around things that were part of the work already. Instead of saying, okay, we're gonna totally overhaul and we're gonna build cyber rounds, and I know Jason Stein and his work is phenomenal with the accountable care units, et cetera. But the admission timeout is like a totally shrunk down version of that, where as a team, me as a nurse, the patient, and the doctor on the phone are doing a version of a mini cyber round at the time of admission. So I think it relates, and there are ways to continue to evolve this. But part of what one of our take homes would be is simplifying the design in as much as the work currently exists, and how do we enhance that?
It's on the horizon.
If I could ask you a follow-up question, I mean, was there much work in terms of educating the staff on sort of lean-based principles? Did you guys basically incorporate PDSA cycles and stuff into this, or was it iterative, and did you create this as a unique issue within your own hospital? I mean, was there any top-down push to demonstrate that a lean-based form of thinking on your unit was likely to improve?
Yeah, and my thing would be we didn't use lean principles at all in this, except for to say how are we going to marry this to the workflow without creating more work. So we didn't actively set out to eliminate waste or improve throughput or those kinds of things with this work, except for in as much as we harvested from the people doing the work, is this going to work, and iterated it in terms of their workflow. So I would say this. I like to think of this as something that's parallel to lean work. So you absolutely need lean processes and PI expertise to drive a lot of this. This I think gets us more to the human experience of work, in how that's experienced by the people on the unit. And not to say that there's not overlap there, but this is I think this is a little bit of a different approach that's complementary to sort of lean engineering design. Yeah.
Can I ask my question now?
Yeah.
So thanks for this talk. This is awesome. Thank you guys for taking the initiative to do something and then coming out here and sharing about it. So I'd like to build up. Natasha had a question at the end of it when you guys kind of focused on that, about the process of things. So I kind of heard a few tidbits about there's like 4 big buckets, and then you guys spent 8 hours, one day talking about it, and then you had the execs at the end of it. And then Lindsay, after this, respectfully hounded everyone to make sure that we're all actually doing things, not just talking and all that fun stuff. So build a little bit on that process, if you guys could, please. And then also to the point about scaling it. So without having this culture within this org that presumably has some motivation to do something and help the patients, how do you go beyond that? So I wonder if you guys have creative ideas about doing it elsewhere.
So I guess the interesting thing about the design day is it was we were given no holds on anything, and it was our ideas. And there was a little piece of paper that Patrick had on his desk with the 4 things that we were going to end up with. And right as we were nearing the end, and we had come up with the 4 things, I happened to look over at his paper, and I was like, what? How did you get us here? These were all our ideas, and how did you know this was going to happen? So I thought that was kind of funny. So it was definitely a lot of organization and thought on the front end of what our big issues would be. And then we were given a lot of space to make those connections for ourselves and to get where he wanted us to get to. The piece about being innovative, honestly, I just think that innovation comes from taking yourself out of your normal environment for a few seconds and thinking quietly, maybe, almost. Because when you're doing the work and you're focusing on the tasks, you're not thinking about how you can do them better, you're just thinking about getting them done. And so I think what was so valuable was getting people out of the floor, putting them somewhere else and letting them think. And that was what gave us energy to do these things, to add to our workflow a little bit, was the energy.
Yeah, the reality is we'd never done this until we just made it up, and we said we're gonna try this because we think there's something there, and we got to figure out something. So we put together a scaffold based on design thinking and some of those principles, and tried it. So that's another take home from my end, is just start and just do something. In terms of scaling it, those conversations are ongoing right now, and with our chief quality officer and other folks who want to see this spread. So we're over time. I see another hand up. I guess I'd look to organizers. Do we have time for another question, or why don't you go ahead? You have the mic.
It's really as much a suggestion as a question, because I think I share your thanks to all of you, both for how you presented this and for the work that you actually made happen in real life for your patients. And I wonder if there's a way that are you thinking about writing this up and with a little more detail about the process? Because it seems like you have done something that lots of other organizations might be interested in doing, and just kind of how might you get out there a sense of the process for people who are interested in replicating it?
Yes.
Mm-hmm. Yeah.
Thank you.
Thank you.
As well.
When can we see that?
We'd be happy to describe the process in detail to anyone outside or after the conference. So. All right. Well, thank you all.
Thank you.
Thank you.